We all do it a little differently. But the basic premise of the table is the ability to move and maneuver the hip around in order to get the implants in. You know, there's an on table and an off table technique. I think Kate comes here a little bit, does it off table, which is probably a little more challenging. It's a good table. We use it for hip fractures as well. You guys don't have to worry about it. It doesn't, so we're here for that. A few basic things. Obviously, this post is critical. It's literally the only thing holding the patient on the table. So whenever you guys, you know, if you're setting this up, make sure this, you know, whether it's male or female, is saddled kind of right down on this post. And this post has to be, it's not in, it's falling off the table, right? This contraption right here is essentially it's a femoral elevator. I do not use it. I think Nick and maybe Paul use it on occasions. If you're setting it up for the hip, it's on the side the hip's on. So if you're coming in first thing in the morning, you're using it. And its job, if you want to use it, is there's a hook that's placed in it under the femur, and you can elevate the femur and lower the femur.
This is something you must check before you bring the patient into the room.
That's why that's why I was saying it. I don't use it, but it should be on the bed. And when it's on the bed, all you need to do is the left hip, put the left one on, and the right hip, put the right one on, and then just make sure that it's connected to the hydraulic. That's it. That's all you gotta do. That's
There's a knob here too.
Yeah,
Left femur, right femur. If it's not working, come check this, because a lot of times it's just on the right femur, but the left femur is hooked up.
so that's also, you know, pretty basic construct. It's got these cool, you know, basically arm holders. You can put your arm holder on it, so you can attach it. It locks into place here. You can lock the arm holder here. So this is nice. When we're doing the hip, the opposite arm holder is typically out. So C arm, if we're doing the left side, is coming in this way. So this side, you know, the arm would be up and over, which we always talk about. I'll get to it. And this arm is typically out. So patient's on the table, we check this, that arm holder's connected, you got a patient on the table. Boots are a pain in the ass, but you know, a lot of people, if they're putting people in the boots, they'll take the boot and you can actually take these out, put these on the leg, and then you can slide this into the boot. It just makes it a lot easier.
Those are not disposable.
These are not disposable.
And you also must cover the patient's foot with Coban, a sock, something, because they're not disposable, so it's gross, right?
Yeah.
So a lot of times you'll see residents trying to just shove food in them. You have to stop them and say, no, 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 we don't do that.
Right. Also, when this goes in here, you got the leg on it, you have to tighten this. I've had a few legs fall out intraoperatively, just, you know, onto the ground because this hasn't been tightened. I try to check it, I make my rep check it, we triple check it, you know, but that's very important. So once they're in the boot, obviously, this piece, you want to move this out so we can kind of just show you how to do that. And we'll go through the arm hold, or the legs positioning. Obviously, once their legs are in the boots, we're spreading these out.
And then talking about the boots, what I would do if you have a female, grab a small. If you have a male, grab a large. Start there. That's 99% of what we would use for each patient. Obviously, there's some people who have massive feet. We may need an XL, but for a female, just grab a small. Male, grab a large to start your case.
Okay. So now, patient's on the table. They're in the boots. We've checked these to make sure they're locked. If we're doing a left hip, which is the setup for it, we want the opposite leg. You know, we want a little padding under, you know, the back of the thigh. It typically sends to kind of sag, and the hip will kind of sag into a little extension, and you can get a sciatic nerve palsy or something like that. So we're putting basically a little elevation under the contralateral leg, just so it's resting comfortably and it's not bridged, you know, essentially.
We also don't want them to be in flexion, we're just putting light pressure.
Just light pressure. So that would be kind of sitting under the other leg. So C-arm basically is coming in through here, okay? This is the left hip. So
Arms up and over.
the whole concept of what we're doing is the leg's positioned in the leg holder. You don't have to do anything at the start of the surgery. If you can think conceptually as to what we're doing, this will make a lot of sense. So the first thing we're doing is we're taking the femoral neck out. Okay, so while we're doing the dissection, you'll see we're getting close because we're asking for a corkscrew, or we got the retractors in, we're taking the caps out, there's a corkscrew in the femoral head, we're getting this off. What we're gonna want is some traction across the hip, so that when I cut the neck, I have a little room to kind of pull it out of the socket. So traction comes in two different ways. This is unlocked. If you unlock this right here, you cannot put traction on this hip. I can go like this all day, but it's just gonna move that manual traction, right? So the first thing you'll do, very lightly, is you'll just pull the leg, pull it under some tension, and you can lock this, okay? Now, if you see how I have the leg here, I have very little room for manual traction once I've locked the gross traction, right? Or the manual traction, and I have very little room for the fine traction, which is right here. So typically when we're doing this, and you got the leg in the leg holder, before you lock it, I always say, you can see, look at how much extra traction you can put once you lock that gross traction. So put this, I'll go all the way out just so you see it goes that far. Put it halfway so that you have room. If you put it all the way here, and then you pull traction, and then I ask for, I'll say like go around the rolled ones, which is this, you can't. So you want to have this at least, 3 or 4 inches exposed on both sides.
And that's something you can do when you're setting up your room.
You can set up room. So
Yeah.
this looks perfect.
Checking
So
your boots, checking the foot pedal, checking your traction.
I'll say pull gross traction. So let's say I say pull gross traction. The other thing that's important is this. This is your little knob, right? This is 12 o'clock, 0 degrees. I call out numbers, all case. They correlate to this degree. So you can see this thing moves. So if you're sitting like this at 80 degrees, which by the way, we're setting it to basically the toes straight up and down. So toes up and down equals 0 degrees. So if toes are up and down and this thing's set at 80 and I ask you to go to 120, we're off, right? So you have to make sure that this is calibrated per se. It's not complicated. We're set at 0. So typically we'll say 20 degrees external rotation. So external rotation, internal rotation, very simplistic. You're rarely going to be doing anything internal. So 20-degree external is always, it's away from the body, okay, away from midline. So 20-degree external, 20, boom. It's locked in traction. I'm cutting the neck, and I'm pulling the head out. Yeah, I'm pulling the head out, you're done for a while, right? So now, hips under traction, heads out, ream in the cup, we're putting the cup in. You'll see that the liner's going in, so you can chart and do your things, or like, when do I have to be back at the table? Once you see that cup kind of getting impacted into the socket and that liner going in, you know that the majority of the work we're gonna have to do is starting, because this is the point of the case where we need to get the femur into a position to do the broaching, right? Can you raise the table up a little bit? So I always tell people, anytime, outside of this final, that's good. Anytime we're dropping and lowering the leg and moving it outside of just gross traction, you should never have traction on. So if the surgeon forgets to tell you to release traction, and you can remember, you're in their good graces, because that's how you break shit, right? So once we're done with the cup and we're positioning the leg, the surgeon should basically say, release the traction. You don't have to do this. This is your fine traction. Just release this, and the leg will kind of release. So now that I would tell everyone will kind of move it back and forth, be like, Dr. King's, the traction's off. So at that point, now we're doing some releases on the femur. We need to expose the femur. So typically when we do that, we're going to have you go even more external. So we're going to tell you to go to 90, okay? If we're telling you to go to 90, and you can only get to 80, and it feels like you're going to break the damn femur to go to 90, don't go to 90. say, hey, Dr. Kinesic, I can't get it to 90. I'm tight, something's wrong. But if you can get it to 90, pretty nice and easy, you just set it to 90. You know, we'll do a few more releases, and at this point, we'll say, we want to drop the leg. This is basically your lever to move this. This thing is locked. Is this the old one or new one?
It's the old one, I believe.
Okay, well, the new one's cooler because this is under a hydraulic, so if you release it, it won't drop to the floor. This one, if you release it and you're not holding it, this thing will just fall.
And it has happened in the case, in the Kinesic room, others did drop the leg, so when you're getting your room ready, know what pet you have.
Yeah, we can figure that out
Just
too.
never let it go.
I would say
Just never let it go.
One of your hydraulics are not working.
So you
That's
now-
all. I'm just saying.
You now have control, complete control over this, right? There's no stemming, it's totally disarticulated from the cup, but if you didn't do enough releases and this drops, you can absolutely break the femur. So we're gonna go down slowly. I'll say start going down slowly. It's the same thing. You'll feel tension. If you feel like it's stuck and it can't go down, you know, just say, hey, you know, I'm gonna stop here. You know, I can't get it to go down all the way. But if we did a good amount of releases, it should go all the way down to the floor.
So,
And as it's going down,
about this too.
yeah, this thing right here is under tension. If you see this red zone right here, if you see this is in the red zone, think of a
By this, he means this. If this box starts getting into this red zone,
think of a really short person,
yes.
right? Their legs on the table, and it's like, man.
5'2" or under, you should be adding this extension, which will help this.
Stay
It
out of the
goes
red
in-
zone.
It goes in here, and then your boot then goes in here, so it
It's a
gives
leg
you that
extension.
much extension.
What we
So
don't
5'2"
want,
or under.
what we don't want is this leg under too much tension. Even though it's dissociated from the hip at this point, you can still put it under a lot of tension, even without traction, which can damage the nerves. And they, you know, like femoral nerve palsy. That's terrible as well. So our goal is as it's dropping, you know, the leg's long enough, stays out of the red zone. And then typically, once it's
So if it
dropped,
is in the red zone, you need to make sure you tell them, hey, it's in the red zone.
and if
a
it's
lot of
barely into it, a
times,
lot of times I'll
we'll
leave it.
just put the bed down like this, and it'll help alleviate some of that tension.
So we get out of the red zone, and then we're typically gonna say we wanna go to 120. Same thing, I always go 90 down, 120, and over. So now we're going to the 120. So all I'm doing is I'm moving this to 120. So you can see where the leg is. It's basically, you know, backwards and externally rotated. And then you can kick it, you can move it, and then I'll say over. So this can stay unlocked. Sorry. And then this basically, just you want to get it as far over as you can. By doing that, essentially now, I have the hip externally rotated, I'm staring at the calcar, you're moving it over, I've elevated, I have my shot at my femur. So we're sitting here, you're like, oh cool, I did it, I got it over. The first time we're doing it, we are broaching for the trial component. Okay, so that's the one thing. You're gonna repeat the step twice. So the first time we do it, we're putting the stem in.
And if you're with Genter, maybe for your first.
Okay, I'm sorry. So we're putting the stem in, and we're happy with the stem. We're putting our head on. You'll see, you know, they'll give the surgeon the neck and the head. So now we have our stem in, cup's already been put in, and we want to reduce this hip. So when we're reducing it, it's the same thing. I'm going to say, I want you to come back over, and I'll say, go to 90 degrees, and I want you to bring it up. You'll bring it up into this position right here and lock it. So now I'm in line. Now I have to get that ball into the cup, okay? This is where everyone freaks out, and it's not that big of a deal. So, traction's off, right here, it's always been off. This has mobility, right? So when I want to put the hip in, I typically will tell you to go to 45 degrees, because my goal is I want to be able to push this in without having you guys have to rotate and torque it. You can break shit. So I'll say go to 45, you don't have to lock it, 45 like this. All I'm asking you guys to do is give it a light pull, because I'm pushing the ball into the cup. And as you pull and I push it in, you'll get a pop in. That's it. Everyone wants to pull on it and, you know, show me how strong they are, and it's cool, but you can think about it, if you're pulling more than I'm pushing, okay, you can dissociate the trial. That neck that sits on the trial, it's held on by nothing, it's just tension. So it's a light pull. If it feels like it needs a little more and I don't have it in, you know, I'll say, give me a little more, and then you'll feel it going. Once it's in, you don't have to do anything. At that point, we're going to 9, we're going to 0 again, and we're gonna get some extras. If you like them, if you don't like them, whatever it is, I'll say, sweet, I love it. At that point, all I'm doing now is I need to take the trial step up. That's not the final step, it's the trial step. So we have to get the final step. So it's the same thing. I'm gonna make you go to 90, okay? And at 90, I'm gonna hook the head of the trial component. I'm gonna say, give me a light pull. You're at 90, and you're just gonna pull lightly, and it will pop right out. I will take the neck and the trial head off, and then I'm gonna say, same thing. It's the same steps. 90 down. Like this. We're gonna go to 120 and over. I'm gonna take the trowel approach out. We're opening the final stem, which is going into the patient with hopefully the final head. If they want to trial again, they can trial again, but for me it's typically the final head. And then I'm gonna tell you to go back up at 90. So this will be you'll go to 90 like this, bring it up. And then we're gonna just go to that 45, off traction, pop it in one more time, and we're done. So, the thought is people get freaked out about internal and external rotation. There's almost no reason you want to drive this into the body, unless the surgeon's asking for maybe another release or he's fidgeting around. So you're always usually externally rotating and bringing the hip out of the socket. So you can imagine this is going to bring it out. The only time you're really internally rotating is just a light pull at 45 to pop it in. It just goes in. You don't really have to rotate it in. Once it's in, we'll make you go back to the neutral position for the x-ray. So this is external rotation, internal rotation. Obviously, this is bringing the leg down. This is adduction, this is abduction. Typically, we're not going to have you abduct the hip. We might, on bigger people, have you move this leg out a little bit so that we bring this down and over. On some of these larger patients with bigger bellies, we can get it further over to bring that calcar and that trochanter further away from the belly. Right, so you can see how much more I can go over now that I move this out, right? That is literally the premise of a hip replacement. It seems maybe like a lot of steps, but I think if, I always tell, know where you are in the case. Look at the x-rays. What's going on? Ooh, the cup's going in. Okay, that means the femur's coming up. So if I'm in the middle of charting like 5 stickers and their codes, probably not a good idea. Because I'm gonna call for you in about 2 seconds. And once you start the femur, you can't do a lot until the femur's done. So if you want to get your charting done, as soon as you pull that traction, and we're working on the hip, cutting the head out and all that until we get the socket in, it takes like 10-15 minutes. You got all the time in the world. Once we come to work the femur, typically you're going to be hanging out around here until the final components are in, and then you can go in. That's typically what people don't like about the anterior hip is we're using you more in the case than a posterior or some other case. So
it's always a good idea to take the computer, this one travels in here, and move it down to the end, and then you're literally right here. So you're not trying to go behind the sterile field, you're not trying to jump through the C-arm to get yourself down here. Just park yourself down here and you're right where you need to.
yeah. What am I missing?
The only thing, so there are 2 different sizes of this. This one's a taller one. He typically likes the shorter one. It's probably like that, so if you guys can go find it. They're just thrown in the bottom of those cards. That's a big thing that I'm having issues with, is nobody is actually putting the pieces back together on the cart appropriately, like they're just thrown on there.
These are size specific,
Everything
there's a
are gonna
left and a
get-
right, and so
Yeah.
there'll be like 2 rights on here
Yes,
sometimes in the morning.
like you just,
A right and left of the same size would be really nice. Okay? You know,
does everybody know, like, how to put the actual boots on, what we're looking for? When you're putting your foot in, you want, see how I can put my finger through? Sometimes even when the patient's foot is in there, you can still do that. You don't wanna do that. You wanna make sure that when you're pushing on it, you can't, like, get your finger through.
And one of the easiest ways to do that is when you're,
Oh,
and when you're putting the boot on, typically, I mean, if I can get it in there out, I mean, they're asleep. I know they're in pain because they have arthritis, but they can't feel it. You can flex their
Knee.
leg or knee up, so it kind of pushes the heel down into the boot, so that when you put your finger here, you feel the heel. You know, once you do that, if you just put it in loosey-goosey and this thing's kind of like this, you know, you're like,
the foot can fall out. It has
when you pull
happened.
traction, this thing pops right
It
out.
has happened. So you,
That would suck too.
I would, if I was a circulator as well, and you're watching the residents, but basically as a circulator, you are responsible for all of this positioning. It comes back on you. So whether or not you're doing it or not, you are responsible. So you need to come, I always check this, nope, not in, yep, we're in. I double check this, I'm double checking that the arm is high enough, like,
Yeah.
it is your responsibility at the end of the day.
Some little intricacies up here that we've just gotten good at. This is our burrito wrap. So if you don't see this on the table, if you could just put a sheet like this on the table, this is how we get the arm up and over. So once they're on the table, if they're if they're a skinnier person, we will bring, remember this arm has to be come up and over. You can imagine if this arm's out or it's anywhere near the operative field, like we can't access that femur, right? So this arm has to be up. This is not up. I'm running into this all day. So I would say the olecranon, the tip, have it pointed at the ceiling. Okay, if it's down here and tucked with a big belly, it's gonna live right
This
here.
sheet actually becomes kind of a big deal too. People don't think about it. They open it up really wide. If you open it up really wide, when you're pulling this over, you're now covering the hip, which is where we're working. So you need to make sure that you have it like enforced, basically, is what I always do.
And then once they're on the bed, we'll put a little pillow or a foam roll,
Yeah.
essentially under them like this, and then we'll bring this arm over
And then pad the elbow, pad the hand the best you can.
like this, and then this is basically just wrapping the whole construct.
And then tape.
And then that's it. You know what?
And then we also put the belt around it as high as we can as well. Because we
I-
want the belt around.
I'll typically come in initially if you guys are doing this, and if you're like, I'm not comfortable with it, or I don't know if it's right, call me, call the resident, we're happy to help, but this is important. If I come in and I see that elbow down here, I'm gonna rip everything off and we're gonna redo it again. So it's important that it gets up and over, okay? So that's why we have, we use these because if you tuck it like this the whole case, you can get yourself, a brachial plexus palsy just because you're basically, you got all your nerves kind of compressed in here. So we want to create almost like a little box, which is why we use a pillow. If they're bigger, use belly, you don't need this. Or belly serves as their pillow, just up and over, right? Large breasts, you don't need it, just rest it right there, and then we'll put it up and over. Short of that, I always tell people, the prep is the case. You get the patient on the table correctly, in the boots correctly, positioned correctly, I mean, that's half the battle. The rest of the case is running the foot holder twice. Everyone knows I pull traction and put it at 20 degrees. So you're not doing anything truly in the case until we're running the femur, which is typically halfway through the case. So once you get the traction on the femur and we're working the acetabulum, you got time, but I really need you guys in the case when we're running the femur. So everyone tries to run around, or they're charged, or they're disappearing because someone calls and they need something out of the back, and we're always waiting, and then I'm having my rep do it, and then I get yelled at. The rep isn't.
The rep should not be touching the table. I know they help sometimes.
Sometimes in really tight hips, when you guys can't hold or release it all the way, they might come behind you, just a little extra, pull the release the hip, but it's very rare.